Hi, everyone. I'm Deb Flashenberg. Welcome to Yoga, Birth, Babies, a podcast produced by Prenatal Yoga Center. We will be diving into everything prenatal yoga, birth, and baby related, hoping to inspire, educate, and empower you through your journey into motherhood. Thank you for listening.
Hi, I'm Deb Flashenberg, and I'm your host of Yoga Birth Babies. And today we're going to talk about the top tips for the pushing stage of labor. So if you are having a vaginal birth and it's time for that baby to make itself completely earthside, we need to get that baby out of your body through some form of pushing. So we are going to talk about the most advantageous positions to birth that baby. And even if your care provider is not keen on having you in other positions than your back, how to get around that. And how to even have a conversation with the birth team to help support what best serves you as the one pushing. We're going to also talk about some adverse outcomes of pushing ineffectively, kind of that purple pushing or perineal tearing or rest in descent or even cesarean. So to have this conversation, I have the birth nurses. It's Shaina Brickner and Liz Wade. They are two labor and delivery nurses with a combined 40 years of experience working in Los Angeles, California. They're both moms, nurses, and childbirth educators and are passionate about helping others have a smooth hospital birth experience. I truly enjoyed this conversation. And what was also great is we didn't just talk about, here are some ideas for birth. We talked about, even with knowledge, even with ideas, what my birth was like, what their birth was like, and how our bodies and babies also have their own ideas of what works. For example, I thought that my baby was just going to kind of walk right out. I thought it was going to be much smoother than it was. And even with all that knowledge as a doula and a birth educator and a prenatal teacher, I used parts of the idea of pushing that I never thought I would. Yeah, I had some definite Valsalva breathing to get that baby out, and I never thought I would. So we go over all of that in this episode. Now, before we get to that, as always, I just like to say a big thanks for being part of our community. Thanks for listening. We are continuing our commitment to our online classes 7 days a week. We have in-studio classes 6 days a week. We're continuously adding more classes. We are now at the point that our online on-demand workshops will match what we offer in studio, which is super exciting. So that if you can't make it to the Upper West Side, we've got our on-demand libraries. You can check that out. So feel free to head over to Prenatal Yoga Center, take a peek at that. We also are be gearing up soon for our next round of prenatal yoga teacher trainings. I finished recently the postnatal teacher training, so I'm taking a little break for the summer. But then we're jumping back in. We have 3 online teacher trainings, prenatal teacher trainings, then an in-person prenatal teacher training in New York City, and then back online for the postnatal teacher training next year. So check all that out if you are the person that wants to support someone in the perinatal community. I've got you covered there. All right, we're going to take a super quick break, and when we come back, please enjoy top tips for the pushing stage of labor. Hi, Shaina. Hi, Liz. How are you?
Good. Hi.
We're doing good.
I'm so excited to jump into talking about tips for pushing because I have students ask about that all the time. But before we dive into that, I would love to learn a little bit more about the two of you and how did you each get into birth work and then how did you end up working together?
Oh, interesting. This is Liz. Birth work. Well, I transferred from the medical surgical department at UCLA into labor and delivery to take a little rest. I'm putting quotes in the air and learn something new. It wasn't that I had a burning desire to do maternal child health or labor and delivery. I just thought I'm going to just choose something different. It was going to be this or the ER. And 33 years later, I'm still here. I started teaching birth education about 7 years into labor and delivery and opened my business, Birth and Beyond, here in Santa Monica, while continuing to be a part-time labor and delivery nurse. And I've been a labor and delivery nurse ever since.
Amazing.
So, yeah, just love it. I thought it was my calling and never ceases to amaze me how much I still enjoy it.
That's fantastic. I was actually just thinking about labor and delivery nurses this morning, and it is such an important job. And I love that you are so passionate about helping birthing folks and staying attuned in the childbirth education world and going above and beyond. So thank you for the
Yeah.
work you do.
It's a lot of responsibility, for sure.
It is, definitely. Shaina, what
Sure.
about you?
Yeah, for me, I was interested in labor and delivery from this moment I started nursing school. My dad is a doctor. He was a family practice doctor and he would deliver babies. And so when I was 17, he took me to a hospital to kind of shadow a labor and delivery nurse. And I was simultaneously shocked and surprised, but also fell in love with labor and delivery. And so that's why I started nursing school, just to be in labor and delivery. But then I transitioned to lactation in 2019. And so now I'm a lactation consultant and I left the hospital setting. But that's where Liz and I met. We met at the hospital where we both worked and where she still works. And I knew that she was teaching birth classes on the side. And I was like, I think I want to do that too. I want to help families before they even get to labor and delivery to know what to expect in the hospital setting for labor and birth, and to help ease the whole process, make it a smooth process. So we take out all the fear, we take out all the wondering, what's going to happen to me and how is this going to work in my body? So I knew that Liz was doing that. I kind of asked her to mentor me in a sense. And so at the same time that I started my lactation training, I started my business Preparented, where I do birth classes and newborn classes and breastfeeding classes. So we kind of just, our worlds meshed together, and then we started our podcast, and the rest is history.
Amazing. All right, so let's dive into your top tips for pushing for labor. So, what do you typically see? I guess it's be more for Liz because she's in the L&D room. What do you typically see during the pushing stage that may not be the most advantageous or effective?
That's a great question. And as a labor nurse, when we get into the second stage pushing part, I remind my patients that there isn't a right or wrong way to deliver. Sometimes there's more than one voice in the room. I lovingly refer to it as the peanut gallery. Lots of people want to interject a lot of instructions. So I think one of the things that's not advantageous for the patient is to be told you're doing it wrong, you're not pushing hard enough. That already puts a negative spin on what we're trying to do. So that's not effective. It's not helpful, just using vocabulary that's negative. Sometimes it takes 20, 30, 40 minutes to kind of get into the groove of pushing till they really kind of get a rhythm down. And then effectiveness depends on several factors, one being readiness. So if you're not ready, that means you don't have an urge. We often call it Ferguson's reflex. That's rectal pressure, or that expulsive, natural expulsive urge. If you don't have an epidural, then it's not productive to be pushing. So we want to make sure that we, sometimes there's something called a passive second stage, meaning fully dilated with no urge. Then the patient shouldn't be forced to push. So it's not advantageous or effective if there's no readiness, physical readiness. Now, some people do push really well, just on sense memory, right? We know how to push. We all go to the bathroom. Some women have already had a baby. They know what that feels like. And if they have an epidural, they may be in their brain and their body is following instructions. And that's great. People say, I don't feel like I'm pushing, but you are. So let's just continue. So we just want to make sure that we're listening to our patient, and if there's no real urge, not to rush that process.
Yeah, it's so interesting. As a childbirth educator myself, and then as a doula, and when I had my own kids, I was expecting more of that Ferguson reflex. My friend called it vomiting out of her vagina. She's like, I just
Right.
couldn't stop it. And I'm like, I get
Right,
it.
right.
I never had that. And, we gave a long rest and be thankful stage. And
Mhm.
I never had that immediate, like, oh my God, I have to push.
Right.
I mean, I eventually did, but I
Yeah.
eventually pushed, but it was so interesting. So I feel like I kind of missed out on that a little bit. I'm
Well,
kind of
that's what I'm
jumping.
talking.
Yeah.
Oh, I'm
Yeah.
sorry. That's what I'm talking about. That passive second stage. Some people don't have that urge, and we just like, well, let's just try.
Yeah.
I don't. And they say, I don't feel like I'm doing anything. I'm like, but you are, and you are going to push a baby out.
Yeah, I definitely thought the pushing looked different in my mind than the
Mhm.
reality of
Yes,
it. And we
absolutely.
and I'd love actually, I'm going to jump a little bit ahead, but the
Okay.
two of you both had babies. And as
Mhm.
I'm reflecting back on my own two birth stories and
Mhm.
how the pushing stage did not match what I had thought it would be. What
Mhm.
about the two of you having already, been doing this work? Did you have a similar experience or was it kind of what you were expecting it to be?
Well, Shayna and I had drastically different experiences. I had a easy pregnancy after some obligatory morning sickness in the first trimester, and then smooth. Come from a huge family. My grandmother on one side had 10 kids. The other had two. Both my sisters delivered vaginally. My mother had 4 vaginal births. So I was very prepared for easy peasy, never gave it a second thought until labor. And I actually had pressure and urge to bear down at 7 centimeters. So I thought, here we go. I'm going to get quick through transition and I'm going to push and it's going to be a done deal. And I ended up having a C-section for a persistent posterior lie. And I never
Mhm.
got past 7 centimeters. So I went right to the operating room after about 35 hours.
Ooh, that's a
Parental
long.
pressure, but no baby.
Oh,
Naturally, I know, right?
And I have 3 kids. My first two, my first, I attempted to go all the way totally unmedicated. And then at 9.5 centimeters, I was feeling pushy around 6 or 7 centimeters, similar to Liz. But they said, nope, don't push. You're going to make your cervix swell. So they had me do these like grunty pushes just to like satisfy the urge that I had to push,
mhm.
but to not do full on sustained pressure to push. So I did that for several hours. And then at 9.5 centimeters, I was like, I can't do this. I need an epidural. So I went through the whole process of getting an epidural, sitting up, hunching over my back, the whole thing. And they put in the epidural and it didn't work. It took like 20 to 30 minutes of sitting and, getting the whole procedure done. And then I felt my left leg go a little bit tingly and warm. And they're like, how do you feel? What's your pain level? And I was like, it's a 10 out of 10. Feels like there's a bowling ball in my butt. And they get on my back, they check me, and they're like, oh, you're ready to push. So I guess I did kind of do that one totally unmedicated, but I for sure felt like vomiting out of my vagina. I call it like you're on a runaway horse and it's just taking you along and you can't stop it.
Mm.
Or like you're dry heaving, but the opposite way because it's just coming and you can't stop it. And then with my second, that was totally an unmedicated hospital birth. And I didn't feel that fetal ejection reflex like I did
Mm.
with my first. I just felt so much pressure and I couldn't even tell if I was pushing, but it was so fast. It was like less than 10 minutes and he was out. So I guess I kind of pushed. I don't know. And then with my third, I had an epidural because I just wanted to see what that was like. And he was posterior. So he was a sunny side up, quote unquote. And I pushed for an hour and a half. I was in a million different positions. Ultimately, they used a vacuum to pull him out. I had done most of the work and they just did like a 30-second, not even 30-second,
Mm.
a 10-second pull with the vacuum and he was out. But the along with being posterior, he also had a really short umbilical cord. So every time I was pushing, they were seeing D cells on the monitor, and everyone's freaking out. There's 10 people in the room, the whole NICU team. And finally he came out. But that was my hardest pushing stage. And I attribute it to him being posterior.
Yeah.
Yep.
But that's so interesting that out of the three of us, so many different experiences. So what's great for the listener to realize is there is no one way to expect it. And even if you've had babies or teach this or been rear babies, the body can have, just such different experiences. All right. So thank you for sharing. I just
What
think it
happened?
highlights. Yeah.
Tell us about yours.
Oh, so my first was very long. I
Mhm.
pushed for about 5 hours with
Yeah.
him. And
Mhm.
I know, I really thought I would just kind of breathe him out. I did not. I did not just breathe him out. I we tried every position there was to do. I ended up, I think by pure exhaustion, I was on my side for a good part of the end, kind of like
Mhm.
passing out between pushes. And I do remember yelling down to my midwife, can't you just pull him out?
Right.
And she did ask, she's like, do you want me to cut an episiotomy? And I'm like, no, I don't. So I think his head was asynclitic. So it took a
Yeah.
bit to finally
Yeah.
nudge him out. And I did what I thought I would not do. And we're going to talk about it later, but I had to use that Valsalva breathing. And
Yeah.
I needed people to count, which I never thought.
Mhm.
I'm like, I will just breathe this baby out. No one needs to count. But if I didn't have somebody counting, I would have pushed for maybe 3 counts. And I know that you do need to make a little more progress than that. So I needed them to talk me through that.
That's
Now, for
great.
my second, it was like 6 minutes. I remember
Yeah.
at one point I was in the shower, they got me back to the bed and I laid down and I literally yelled, I think something's coming out. Now the bag of water hadn't broken, so it was the bag first and then it broke and she was out and like, I don't even really remember pushing. It was like 2
Fantastic.
contractions. I know.
Amazing.
So
Fantastic.
very different. And it's funny because the kids are kind of the same. My daughter would be like, I will do anything to help you. And my son's like, how hard can I make this? So so it
Yep.
started at birth.
That's great. That is
So
great.
yeah. So again, just for the listener, it's just so nice to hear that even with certain intentions and ideas, pushing can show up in so many ways. And as we've even discussed, it has a lot to do. Is it a short cord? Is it the baby's head position? There's
Mhm.
so much. So let's circle back to, we talked about advantageous positions, effective pushing, but what have you seen? What are some of the adverse outcomes you've seen from pushing ineffectively?
Well, now we get into a few of my little pet peeves regarding
Yeah,
pushing.
let's jump
So,
in.
one of the issues surrounding ineffective pushing and adverse outcomes is vaginal or pelvic floor injury.
Mm,
When I see a patient, if I take over a patient and she has a terribly swollen perineum or is bleeding and no sign of delivery in sight, I consider this an injury. And this is an injury caused by overzealous labor nurses, midwives, and obstetricians when they're doing overactive perineal stretching. There is
mm,
no evidence that this vigorous perineal stretching shortens the second stage. Sometimes a very gentle exam, some pelvic floor pressure through the vagina can help a patient locate that sweet spot where to push, right?
hmm.
But this prolonged, ineffective pushing contributes to hemorrhoids, to exhaustion, and the patient starts to feel defeated.
Yeah.
So the outcomes of pushing ineffectively are those things that if it's not helping, we need to switch it up, and we may need to wait. Sometimes, if a patient doesn't have an epidural, she may need permission to have one if she's pushing ineffectively or not able to push because she's too distracted by the discomfort. Maybe take a rest.
Hmm.
And if she doesn't want an epidural, that's fine, but we need to change up the routine to help minimize pelvic floor injury, exhaustion. Yeah.
Yeah.
Another thing is nerve injury in the legs. So when someone's
Huge
in the
problem.
thotomy position, they're on their back, and then we say, put your knees back as far as you can, like towards your ears. And we're stretching their legs out to the side, their knees out to the side, and we're pushing them back towards their ears.
Mm-hmm.
We're probably, and let's assume they have an epidural, and so they're numb, they can't feel their legs. We're probably overextending their natural range of motion and
Mm-hmm.
causing nerve
Absolutely.
injury.
Also,
So,
labral
That's a good
tears.
point.
I've had students come back from having their knees pushed back too much and labral tears in their hips. That's
I completely agree. Absolutely. Labrum, like again, the perineal nerve injury, pelvic floor injury, symphysis pubis injury. I've
mhm.
had a couple of patients over a couple of decades end up in a large orthopedic surgery, literally putting a plate on the symphysis bone because there's been
oh,
full
geez.
separation.
Oh my
Yeah,
gosh.
this is overzealous. People start pushing on my patient's knees. I am constantly saying, please ease up, please stop. Or
Mhm.
I prefer a closed kneed position. Obviously, we want to open
Yes.
the pelvic outlet. You'd be surprised how much resistance I get to just good new literature about more advantageous pushing positions.
Well,
Yeah.
actually, I want to dip into that, but I actually tell my
Yeah.
students for them to be the ones pulling their legs back because they're going to feel where there's
Mhm.
resistance as
Exactly.
Yes.
opposed to somebody else yanking their knees back. And then let's start to talk about that position thing
Mhm.
because I feel like it's now gotten a little more common idea of how the pelvic outlet works that
Yeah.
when we're externally rotated, which a lot of people are when their legs are being pushed back because the hips are
Mhm.
more flexible that way, that we're
Yes.
actually closing the outlet as opposed
Yes.
to opening it. We think we're opening it because it looks like you're stretching the muscle tissue, but bone wise, you're actually closing it. And we know
Exactly.
that internal rotation widens the sit bones. We also know on your back pushes the sacrum into the pelvis.
Into
So
the
I've
pelvis,
had
correct.
yeah, so we're actually making the doorway smaller. Now,
Mhm.
I talk about this in prenatal yoga all the time. And then I have students go to their care provider and say, okay, what are my pushing positions? They'll be like, oh, whatever works for you. But then there's a difference between pushing position and what the care provider considers catching the baby. And they may be
Hmm.
very different. So where the student feels like, cool, I talked to my care provider, we talked about making the most space, but how did I end up on my back?
Right.
So how do you think we can talk to care providers about that?
Okay, first, I want to make sure that everybody understands that most of your pushing is going to be done with your labor nurse. Okay. If you're in a hospital setting, I'm just assuming we're talking about a hospital
Yes.
setting because Shaina and I are hospital nurses.
Yes.
I've done home births with midwives, which is nice. The very last one that I did was a friend who had doulaed all of her babies, and she birthed her last one in her bathtub, and it was fantastic. She could do whatever she wanted. But in the hospital setting, it's usually the OB that has objections to alternative pushing positions. And what I interpret that as the provider is uncomfortable with other positions like hands and knees or side lying. The other thing is, I don't really like when I hear language like, well, I'm trying to talk my doctor into, or I'm trying to let my doctor know that I want to. We as patients need to take back sort of the agency and say, these are the
Mhm.
positions that I'd like to try, and I am going to try these.
Mm.
If there's a position that the baby doesn't like, and when I say baby goes on one side, we get decelerations or late decels. Those are problematic if prolonged. Or if you have an epidural that's too dense, you can't get into hands and knees. But patients and nurses should be trying several different positions to see what works. So it's that permission asking that's problematic language for me. These are the
Mhm.
positions I would like to try, and this is my intent. That's what I think might help.
I think what helps a lot too is the laboring person and her partner taking a class together where they hear
Mhm.
this language, and then the partner can be the one to advocate for these different positions and tell the nurse. So we're assuming that the nurse is going to be more likely to be okay with these different pushing positions, which normally she is.
Mhm.
Um, and then the partner can be like, hey, remember how we learned about side lying internal rotation of the femur pushing. That's a long name for it, but just side lying pushing. And then the nurse could be like, oh, let's try that. Yeah, let's get you into that position. And then you see how it works. You see how effective she can push in that position. If it's not working out, then switch to your hands and knees. But when all the onus is put on the laboring person, sometimes her mind just isn't going there. She's just thinking, I'm pushing as hard as I can, or I'm just trying to get this baby out. She's not thinking about her notes from her birth class about all the different pushing positions. So if a partner, a doula, someone else, or maybe you talk to your labor and delivery nurse before you even got to the pushing stage and you said, this is really important to me. I want to try out all these different pushing positions to find out what feels best and what works best. And when my provider comes in the room and is asking me to be on my back or whatever, I'm going to say no. Or I need you to help me advocate that, like, whatever position I'm in is the one I want to stay in because it's the most comfortable. Now, let's just imagine that that's not going to happen. And the provider comes in and says, get on your back. And you are not wanting to put up a fight. You comply, you get on your back. We can adapt the back position to be more conducive for pushing. So what you can do is roll up a towel or a sheet, slide it under your right hip. This is going to kind of tilt you so that your sacrum, your tailbone has a little more space. It's not flat up against the bed. And you can have one of your knees internally rotated instead of both knees driven backwards. Maybe one knee is back, but then the other one is internally rotated. So we can modify this a little bit. So we're kind of, obeying our provider, or, what they ask. I hate saying obeying, but then we're modifying it to help open up the outlet of the pelvis.
And it's also an expectation of the nurse advocate also to be able to say, we're doing really, really well in this position, and this is what this patient's decided, and this baby is going to come out in the next few minutes. So how about we just do this?
Yep.
Yeah.
I like those suggestions. In fact, I want to go further into that. We're going to take a super quick break. When we come back, let's talk about how to get the nurse on the birthing team. We'll be right back.
Spin your passion into a business with Shopify and break sales records with the world's best converting checkout. Let's hear that one more time. The world's best converting checkout. Shopify's legendary checkout makes it easier for customers to shop on your website, across social media, and everywhere in between. Now that's music to your ears. Any way you spin it, you can be a smash hit with Shopify. Start your $1 a month trial today at shopify.com/records.
Okay, we are back. So I really like what you said about using the nurse and bringing them into the team. So I guess, how do I go into this? What if the nurse is resistant to being on the team and be like, yeah, let's get you with your hip elevated? What if they don't have that knowledge as well?
Okay, great question. And again, as a labor and delivery nurse, I'm going to tell you that the dynamics in labor and delivery have become almost unrecognizable because there's so many team players. Sometimes you have a nurse who's trying to have a relationship with their patient and have these conversations, yet there's maybe other people in the mix, and the patient doesn't want to communicate directly with the nurse. They prefer to talk to their labor support or doula. So first we have to figure out what the dynamic in the room is. And I have spent more time in the last 2 or 3 years trying to navigate my way through labor and delivery nursing, as a doula, a birth educator, and a labor nurse, where I fit into, and I'm putting quotes in the air here, Deb, the team. I want to establish a relationship with my patient, but sometimes there's obstacles for the nurse to do that. So if I have a patient who's open to having conversations with me, then I'm already 10 steps ahead of the game. I'm batting 100. I'm doing great. And if I have a patient who is resistant or doesn't trust me, or it's been set up not to trust where she's chosen to deliver, then I'm 10 steps back. So I have to get that relationship off the ground. Now, if a patient says, look, I'm just not feeling it. I don't feel like this nurse is knowledgeable. She's rigid. She isn't allowing me to have a conversation about positions that I want to be in. Then she is completely welcome to ask for the charge nurse and make an assignment change.
Mm-hmm.
However, remember that labor and delivery nurses are not just looking at you, but we're also looking at your unborn baby.
Mm-hmm.
So what I'm looking at is the fetal heart rate monitor, because I'm obligated to act on what I see. So if there's a position that my patient is in that the baby is reacting to negatively per hospital, okay, let's keep in mind, I understand we're talking about institutionalized birth, then my suggestion is going to be to do something to try to alleviate that problem, right? So there's that whole thing. So those are the three things. Do I have a relationship? Have I been allowed to have a relationship with my patient? Is the patient been very well educated on institutionalized birth and what I am doing as a labor nurse to deliver care per my hospital's area standard of care? And is it just a total breakdown in communication with the nurse? So those are the three things that we're up against to try to, get in there and maintain or even start a relationship with our patients.
Mm-hmm.
Yeah.
And then I liked what you were saying about using, if the relationship is made and the laboring person feels like the nurse is on their team, then using the nurse to kind of sidestep the idea that the care provider would be like, okay, get on your back. That's really, I like that. So let's also talk about then how to possibly sidestep Valsalva breathing, because I get a lot. We teach a TA, a transverse abdominal toning in class, and then teach about how you can use your breath and your body to push baby out instead of just holding your breath and feeling like you're creating more tension in your face and neck and pushing down. And so I've had students say, I was all ready to do that breathing that I practiced for months in class, but my care provider wanted me and I understand intra-abdominal pressure. I get the idea of holding your breath, but how does that conversation happen? And what if there is not space to have that conversation?
I think there's like a mid, like a we could meet them halfway. So instead of doing full on like breathing your baby out, I've found that you can kind of fake it, like fake the holding your breath and also fake the breathing your baby out by doing this middle way, which is open glottis pushing. So you're taking a deep breath, but you're tightening and you're imagining wrapping your abdominal muscles around your baby, and you're holding all that pressure in your abdomen, but the pressure isn't in your face. Your eyes aren't about to bust out of their head. And you're still keeping the flow of air coming through your glottis, but not like you're pursing your lips and blowing out.
Yeah.
But I'll try to do a demonstration here, but you take a deep breath, you tighten your abdomen, and now I could still let some air through my glottis, but I wasn't letting out the air completely until I reached the 8 to 10 second mark of sustaining that pressure. So that's called open glottis pushing. That's what I teach all of my birth class clients. In the hospital setting, there's so much going on. Everybody's yelling at you, push harder, go, go, go. And you feel this intense pressure to do exactly what they're saying and exactly to perform. And then you're doing exactly what you didn't want to do. So I think it requires, again, the partner is huge in this. Some patient advocate to say, oh, we practice this other kind of pushing. Instead of you yelling at her or, yelling at me, can you be the counter, or I'd like to be the counter, and she's going to push this way. And I mean, the proof is in the pudding. When the nurse can see that it's working, then she's not going to scoff at it. She's not going to be like, do it my way. She's going to see that what you're doing is actually effective. And we got rid of that Valsalva purple pushing where your face is, all red
and it's
purple.
actually adding more tension. If we think about that, we know that when there's tension in the mouth and the throat and the neck, it actually creates tension in the pelvic floor. There's a relationship there. So if we can keep, I call it a soft face, like not even pursing the lips, because that's also tightening. So if we can have everything soft and use the breath and use your core and use your belly, a lot of people find that effective. But again, not everyone, like as I mentioned, like I thought that's how I would push out, but I literally was like taking every ounce of effort to get that baby out. So I guess we never really know.
And sometimes it's just a matter of changing it up. Yeah. I might have somebody do closed glottal pushing a couple times. I also like grunt, 3-4 second grunts, especially when the baby's right on the perineum, to help that if that baby's coming really fast, to minimize tearing, just to kind of grunt the baby out and so we're back to whatever is working and that's comfortable. Yeah.
Yes. Are there any tips that I didn't ask about that you want to make sure that we hear?
I think that communicating with your caregivers obviously is the most important thing. You don't often know your OB until you give birth, because your OB may have been your gynecologist for several years. Right? So when you have those conversations in the office, trying to get them to translate once they get into labor and delivery can be difficult. So communicating with your caregiver, allow your labor nurse to establish a relationship with you, even if you've hired labor support. Because if there's that fear in the room of us against them, cortisol levels go up, adrenaline goes up, it's more difficult to bring that oxytocin into your body. I find your support teams are the most important part of it. Having a labor class where there's people to talk to. I have a lot of patients who take online classes and they don't really have anybody to talk to. They don't have anybody to call and say, can we go over A, B, and C again? Coming into the hospital, defensive and suspicious frame of mind contributes to a less optimal outcome. I truly believe that. Yeah. So a good education, open-mindedness, communicate your needs, and allow yourself to have a relationship with your nurse as well. She is part of the team. I say she because most labor and delivery nurses are women right now. And, there's more postpartum nurses who are coming in, who are joining our team, which we love. And I think it's important. I think that's the most important thing for me, is just being relaxed when you come in and not in a defensive mode.
I really like that. Yeah.
I have another thing that we didn't talk about. So when I teach my birth class clients, I tell them to imagine that they're pushing out the letter J, or like a curved pipe, so that they're pushing forward and a slightly up instead of down and back towards the rectum.
That makes total sense.
Yeah. So sometimes it helps people to imagine, I don't know if you've ever done this, but pushing out a tampon with just breathing. So you're pushing out your vagina, right? And that's where your baby's going to come from and come out of. When we tell people to push like they're pooping, we're telling them to put too much pressure towards the back, which actually increases their risk for tearing. So when they can imagine that forward and front pushing, I think it helps reduce tearing, as well as putting a warm, wet washcloth on their perineum while they're pushing. Or doing some sitz baths starting at like 36, 37 weeks. Doing a sitz bath for like 15 minutes once a day can help loosen up that tissue, so that we don't even need to go to that intense stretching and, perineal, quote unquote, massaging during the pushing stage. So we have less tears, less lacerations in the perineum and the
I
labia.
love that idea of pushing a tampon out instead of pushing a pooping out. I love that. I also think I'd also be curious if you have less pelvic organ prolapse because of the pushing more towards the back than the front.
Right.
But I did an interview with Dr. Rachel Reed. She's an Australian midwife, and she talks a lot about get the hands off the perineum unless it's like she's like, there's a lot happening fluid wise. That in itself is softening the tissue. And she said the only thing, if you're going to do anything, put that wet washcloth, but otherwise get the hands off there.
Hands off is my big thing. Hands off. When I see young nurses or nurses teaching younger nurses for vigorous perineal stretching, I literally wish I had a ruler in my hand. Like, get your hands out of there.
Yeah. And what was really interesting, I remember as a beginning doula, when I saw them doing that massage, I actually felt like I saw these little pinpricks of blood. And I'm like, are you making it more friable? I'm like, it's just.
Oh my gosh.
No, you're making it more friable.
Yes.
That's what you're doing. Yeah. Like I said, if my patient is swollen and bleeding before, an hour before the baby's born, you've caused perineal injury.
Yep.
Yeah.
There's no reason for it. Hands off.
All right. So listeners, we've got some really good tips here. So I hope you got a lot out of this. We're going to take one more break. And when we come back, if you each want to leave us with one final tip or piece of advice for new or expectant parents, it can be from anything in your wheelhouse. We'll be right back. We are back. So what would you like to leave us with?
Shaina?
Oh, yeah. Well, I'm always thinking about breastfeeding and lactation. So, I think people focus a lot on birth. It's kind of like the wedding day. You focus on preparing for this amazing big day, and you're like calling all the vendors and you're making sure you have everything in place. And then marriage, and, then the baby and breastfeeding and feeding this baby. And so my best tip, my final piece of advice is to take a breastfeeding class, to find a lactation consultant while you're pregnant, to take a prenatal breastfeeding class, and set up a postpartum lactation visit within the first week of getting home with your baby.
I love that. All right, Liz.
I would say most important thing, find your support team. Make sure, if you can possibly, get a hospital birth-based labor class if you're going to deliver in a hospital. I know people come in and they're very, very surprised at how things are done, even when we're very flexible. Lots of times I go in, say, whatever you want to do, as long as I can monitor the baby a decent amount of time every half an hour, I'm good. But I'm often very surprised at how little people know about the institution, and it is. And whether that's good or bad, being knowledgeable so you're not caught off guard. I think it's every birth educator and every doula's responsibility to make sure that your patient or client knows what's going to happen, and it kind of alleviates the fear, and that's the most important thing to me.
Amazing. Where can people find your work?
I am at birthandbeyond.net. I do online Zoom classes, so I have people in different time zones, which is nice. So I don't have to be completely, just having patients in Los Angeles. So I have sometimes clients. I only take 4 or 5 couples at a time. It's an online class, a full day intensive. birthandbeyond.net.
Amazing.
And I am most active on my Instagram page, Preparented. That's Preparented, like a prepared parent. And I also have a website, preparented.com. And that's where they can schedule a lactation visit or a class and see all of my services that I offer. But on Instagram, I like making videos and just free content. But also for Liz and I, we have our podcast called The Birth Nurses, and we'd love for you guys to take a listen to what we have to share over there too.
Thank you so much. I really enjoyed this conversation. I think the pushing stage is something people don't often think about, and you give some wonderful tips because it's a big deal at the end. You gotta get that baby out. So thank you.
Thank you so much. Really enjoyed it.
Thanks.
This has been an episode of Yoga Birth Babies, produced by Prenatal Yoga Center. You can catch us on Facebook, Twitter, Instagram, and Periscope. I'm Deb Flaschenberg. Thanks for listening.